Hello everybody and welcome to today's Connect and Learn webinar. Today's topic is HepReady, viral hepatitis for AOD workers. And before we get into our webinar today, I would like to acknowledge the traditional custodians of the land where we're recording from today, the Wurundjeri people of the Kulin Nation. I'd like to pay my respects to elders both past, present and emerging, and also acknowledge and pay respect to any Aboriginal people that are watching with us live today, or also people watching as a replay. So welcome. Today's Connect and Learn webinar is funded by the Department of Health and Human Services and hosted by Turning Point. We provide these throughout the year. There's actually 10 Connect and Learn webinars throughout the year, and the intention of these is to provide up-to-date information and training to AOD workers who are both in metropolitan but also regional Victoria. So look out for others, and at the end of this one today I'll announce the next topic that we've got as well. So my name is Sheridan. I'm going to be the facilitator of today's webinar. Part of my role is to watch for all your comments, feedback and your questions that come through today, and to collect those and then present them to our presenter today. So we'd like these to be as interactive as possible, so we encourage you to use the facility on your screen to give us any feedback or ask any questions, and you can do that along the way today at any point, and I'll be collecting those and then, as I said, presenting those to the speaker. And so please just, give us the feedback and those questions. The other thing we wanted to do too is to ask if you're able to stay right to the end of the webinar today, because we have a feedback survey. So once the webinar is finished, it'll look like the screen is closing, but we're actually going to send you on to do an exit survey for us. And we really appreciate if you can take just a couple of minutes to fill in feedback, but also we're really looking for some ideas about the kind of topics, or if you have presenters in mind that you really love to see in one of these Connect and Learn webinars, give us some information about what you'd like for the future, so we can get planning for the end of this year and also into 2020. So thank you for that in advance. So today we're really lucky to have a very experienced trainer with us. It's Stephen Taylor, who's been travelling around the state delivering HepReady training in a face-to-face capacity for the last year. And Stephen has over 15 years experience working in the social work field and the community health sector, working for a lot of different organisations in and across Victoria, including homelessness, housing, harm minimisation and case management. So a lot of experience working with community, and a lot of experience, doing this training in a face-to-face setting. So really grateful that we have Stephen with us today to be able to provide this training that, we know a lot of AOD workers haven't been able to get to the face-to-face training like they'd like to be able to. So without further ado, I'd like to welcome you, Stephen. Thank you so much for spending your time with us, and I will hand over to you.
Thank you. And thank you to everyone listening to us today, or listening to us later as a recording. So I'm here today for Hepatitis Victoria, and I've been in the role for, we're coming up on the end of a year. So what we're going to be talking about today is viral hepatitis in the context of alcohol and other drug workforce, but that really extends out to residential rehabs, dual diagnosis. The nature of viral hepatitis doesn't change depending on who's listening to it. So the information is fairly generalised. However, at certain points we are going to be going into harm minimisation, some of the barriers to treatment, and just to echo what Sheridan said, if you have any questions, inevitably you will, because we're only speaking for a certain period of time here. Please do chime in with some questions. So again, just to echo Sheridan's sentiments, just to acknowledge the traditional owners of the land on which we're meeting on today. And also just to acknowledge that I am going to be speaking about viral hepatitis from a lived experience perspective of the hepatitis C virus and of a previous form of medical treatment, which does inform the picture about why viral hepatitis is such a problem to treat in Victoria and Australia and in the world. So the learning objectives are fairly simple. So I'm just trying to basically increase your awareness of both the hepatitis B and C viruses, and that goes through how to prevent them, testing the medications, vaccinations where relevant. Secondly, to try and build your capacity around how to assist people managing either of those chronic conditions, B or C, and what services are available for them. So yeah, I really want to leave you with at least some guideposts about what services are available, how you can access them, and how they're relevant specifically to alcohol and other drug workers. So the topics, how that breaks down, we're going to spend a bit of time talking about hepatitis B and C, in both cases about how they're transmitted and how they're not transmitted. Who are the priority populations or at-risk populations, and most importantly, testing and treatment. And then really focusing in the second half about less about the physiological side of things and more about how that translates to the real-world problems of stigma, discrimination, privacy and disclosure, and maybe a little bit on how to broach those topics with people you're working with. Assuming the audience are drug and alcohol support workers. And leaving you with a brief overview about what services Hepatitis Victoria does offer. So, just to get the ball rolling, what is hepatitis? When we're talking today, we're talking about viral hepatitis, but this is just to recognise that hepatitis is just a general term. I think there's a couple of exceptions to this, but generally any word ending itis is always going to be inflammation, so arthritis, bronchitis, meningitis, etc. In this case, hepatitis is just hepa being, I think, Greek or Latin for liver, itis being inflammation, and the liver itself, is the filtration system for your bloodstream. It does many other functions as well. It's involved in regulating hormones, but basically the main thing it's doing, it's the detox for your body. It's the only detox your body needs, and it's the only detox that will in fact ever work. So hepatitis has a number of different causes. We have autoimmune diseases that can cause it in a person without any kind of outside influences. Alcohol consumption, fatty liver disease, some medications can cause liver inflammation as well. But in the context we're talking today, we're talking about the viral infections. Now, you might be wondering why just B and C when there's A through F, and I think even G and H at this point. B and C are the bloodborne viruses. Hepatitis A is simply food poisoning, as is D and E to different extents. So yeah, we're talking mainly about the bloodborne viruses here, B and C, but I will give you a brief recap about A as well. So the liver. It is the largest internal organ in your body. It sits right at the bottom of your rib cage. It's the filtration system for your blood. So it prevents any toxins getting into your blood, or it certainly tries to, and it removes any toxins and any blood contaminants there. When you have the bloodborne viruses of either B or C or both, what is happening is it is leaving behind, in the simplest terms without getting too much into the biochemistry of it, it's leaving behind deposits that build up in your liver, make it a less effective filter. Just like if you're using the vacuum cleaner at home, you don't change the filter the fourth or fifth time you're trying to vacuum your carpet. If you're lazy like me and you're not changing your vacuum filters as often as you should, it's not working as properly. Unlike your vacuum cleaner filter, you can't just take it out and bang it on the side of the bin. You're kind of stuck with it. So hepatitis B and C are causing the filtration system for your blood to break down, and you can perhaps imagine that becomes a problem. The liver, it should be said, is an incredibly robust organ, in fact much more so than virtually any other organ or system in your body. It's capable of regenerating itself from losing up to a third of its actual physical matter. It will grow back. But hepatitis, as something that's in your bloodstream, is going to cause it to break down. So the slide you should be seeing is of a healthy liver. Bright, deep red colour. As as you have hepatitis existing in your system for a while, you start to get buildups, as I mentioned, and you get into fibrosis, granulation, scar tissue, and you end up with a fibrotic liver. This is basically, and just in real physical terms, where it is just clogged up, and that is preventing the blood purification that the liver would otherwise be so good at doing. Left on a long enough timeline, fibrosis will develop into cirrhosis. One of the barriers we have to treatment is that this process that I'm just quickly giving you a few slides through, it is a very slow acting process. Your mileage may vary depending on the individual and other exacerbating factors, but the process we're describing here, going from a healthy liver to fibrosis to cirrhosis, can take years, decades. In some acute cases, it can happen a lot more quickly. Some of the risk factors about just the basic healthy lifestyle stuff of looking after your liver, alcohol consumption can definitely exacerbate it. Cirrhosis is basically where your liver is really starting to break down and not doing its job properly. The liver is becoming decompensated, and that's leading to a lot of other flow-on problems in the body. On a long enough timeline, cirrhosis will develop in, I think, up to 50% of cases into liver cancer. I don't need to labour the point about cancer too much. Liver cancer, it's not your friend. You don't want to end up there. Part of the problem with this progression is that it is incredibly slow acting, and the symptoms are not as apparent to people. It doesn't come on as acutely as, say, some other medical conditions. So the symptoms are mainly, the big one is jaundice, joint pains, fatigue, you can get brain fog. These are symptoms that are fairly easy to misattribute to other conditions. When I was diagnosed with hepatitis C, there was a lot of language in the medical system around stable carriers or healthy carriers. And certainly in the last couple of decades, they're trying to get away from that, this idea that you have hepatitis and it's a benign thing that one day is going to become a problem. The public health message that I think is much more akin to how we should be looking at viral hepatitis is, say, every cigarette is doing you damage. For every day that you have viral hepatitis in your body, you are somewhere along that timeline between a healthy liver and full-blown liver cancer. But as I said, it's a slow cumulative process, partly hampered by the fact that the liver is so good at regenerating itself. So nonetheless, left long enough, the liver will develop those cirrhosis and fibrosis problems, which will have these flow-on effects. So I've got a fairly dramatic graphic there about a time bomb. But that's really the kind of the state of affairs. So we really want to get away from any idea that you can live indefinitely with hepatitis, because on a long enough timeline it does develop into a cancer. So it really does need to be treated. The only way you can really assess these symptoms that I've listed here, fatigue, loss of appetite, jaundice, then that's not a diagnosis. The only way to really diagnose that you have hepatitis or you don't is by getting blood tests. And we'll go into a little bit more detail about the blood tests for hepatitis B and hepatitis C. In terms of assessing where you are at on that timeline between a healthy liver and an end-stage, decomposed liver, is by getting a fibro scan. So it's a non-invasive procedure, basically an ultrasound, and that determines, the level of scarring that's built up in your liver over time. So that's basically what hepatitis is doing to your body and why it's a problem. So I mentioned that hepatitis A, I don't want to spend too much time talking about this because it is distinct from the bloodborne viruses. Hepatitis A is food poisoning, specifically by contaminated fecal matter getting into food and water sources. Where you're going to find hepatitis A is where you get a breakdown in access to clean food and water sources, public health, sanitation, which of course is kind of tantamount or paramount with health literacy, access to proper medical care, social services. So, and you'll see this as a pattern when we talk about B and C as well. The priority populations are the ones who already carry a lot of burdens of disadvantage, both in Australia and globally. So hepatitis A is something that in metropolitan Melbourne, throughout Australia, even regional Australia, you're fairly unlikely to encounter most of the time. And it's possible that a few years ago I might not have, in a similar presentation, given this much time to hepatitis A, but it is unfortunately making a bit of a global comeback, particularly in North America with the rise of homelessness, which directly translates to poor hygiene conditions. We are seeing hepatitis A on the rise. There's a similar story in Australia in terms of outbreaks in the correction system. We've had the frozen berries and pomegranates scenario that happened a couple of years ago. So hepatitis A, it's an acute condition. If you have it, you will be highly infectious for a couple of weeks, and we currently have no medical treatment for it. So this is distinct from B and C. It's not going to go on to become a chronic problem, leading to cirrhosis and fibrosis. But it is going to cause a flare-up for a couple of weeks. So if you have hepatitis A, it's recommended that the only real medical treatment we have is basically just bed rest, and to avoid contaminating others. So it's basically food poisoning. If you've ever been to a travel doctor, you would have likely and really should have been given a hepatitis A shot for regions of the world outside of Australia. If you're travelling to, that's where you're more likely to encounter hepatitis A. In the Australian context, the burden of disease is carried disproportionately by Aboriginal Torres Strait Islander communities, particularly in remote regional settings. So that's the bad news. The good news is there is a vaccination available for it. And as with the other conditions I'm talking about today, priority populations are those who have been assigned free treatment. So the vaccination is available for free to Aboriginal Torres Strait Islander populations, to injecting drug users. Men who have sex with men is listed here as one of the priority populations. So that really perhaps should be expanded just to recognise that any anal sex, any sexual activity, there is of course a higher likelihood of fecal matter becoming part of the scenario. If you're wondering why that population is listed. So a vaccination is available, and it does give you lifelong immunity. And most GPs should be able to help organise that for you. That's a public health program that it keeps getting extended every year. So currently, that is still available up until the end of the year, the free vaccinations. So that's really all the time I want to have to talk about hepatitis A. But look, practically speaking, you're fairly unlikely to encounter it. B and C, you're more likely to encounter those as far as bloodborne viruses working with people in the drug and alcohol sector. So hepatitis B and hepatitis C, what is the difference? As I mentioned earlier, I don't want to get bogged down too much in the biochemistry or the pathophysiology of it. The differences really are just on that level. One is a retrovirus that writes itself into your DNA cells. That's hepatitis B. Hepatitis C is something that physically attaches itself to your blood cells. What this translates to are the differences in treatment. Why I'm going to talk about some treatments for hepatitis B and and those aren't relevant for C. Other than that, as far as the symptom profiles of, someone presents to you, they have hepatitis B or hepatitis C, you're really looking at those same things: cirrhosis, fibrosis, jaundice, and the deterioration of your liver and the flow-on effects there. If you're curious to go into a little bit more detail than we have available in the discussion today, I've put a little link here to an American Hep B website, which that particular article there will highlight differences between B and C. There are actually other articles that go right through the spectrum of talking about the difference between hepatitis B and A, B and D, and so forth. So if you want to do a little bit of extra reading, really just for your own curiosity, I welcome you to check out that link. As a drug and alcohol support service practitioner, that level of knowledge is definitely not something you need to be aware of too much. I'm just trying to really give you a background about what's going on with viral hepatitis. So moving on, what is relevant is how do you get hepatitis B? How do you get hepatitis C? So we're talking about transmission pathways here. Hepatitis B, the way it's transmitted, broken down here into three distinct ways. It is a blood-borne virus, and what that means is blood of a person who is carrying, who has hepatitis B, has to get into the bloodstream of a person who does not have it already. People can be a bit confused about exposure to blood and what that actually means. That doesn't mean getting the blood on your skin. That doesn't mean ingesting it even. It means that the blood that's carrying the Hep B virus, infected blood, has to be getting into your bloodstream through an open cut, some trauma to the skin, some opening. A colleague of mine at Harm Reduction Victoria has a rather graphic analogy that I'll use here. You could stand barefoot in a bucket of infected blood and not catch the disease. That is, unless you actually had a cut or an opening into the bloodstream on your feet. So I don't want to over-exaggerate the likelihood of that exposure. You do need a direct transmission pathway. The second pathway is really an extension out of that first one. So this is a blood-borne virus carried in the blood. With hepatitis B, the infectious quantities, contaminants, are carried down into the sexual fluids as well. So vaginal secretion, semen. But I want to stress here that those fluids have to be getting into the bloodstream. So you may find some conflicting information on the internet about is hepatitis B considered sexually transmissible or not? Does that qualify it as a sexually transmitted infection? But just to be clear, physical contact, sexual fluids will not result in a transmission. It's only if the access to the bloodstream occurs during those activities. So rough sex, more prevalent for anal sex, etc. The third way is through what we call vertical transmission, mother to baby. So of all the Hep B virus that exists in the world, this is in fact the main transmission route that we're seeing. During pregnancy, a mother who is carrying the hepatitis B virus is in fact extremely likely to pass that on to her unborn child. Because of that, you can imagine, you can see that accounts for a lot of the hepatitis B in the world, which in fact there is more hepatitis B in the world than hepatitis C. So I'm trying in this presentation not to rely on statistics too much, but if you wanted to put a number on it, it's something like 90 to 95% chance of a pregnant woman passing that on to her unborn baby. So yeah, that is why we're kind of seeing endemic hepatitis B. It is passed on through family lines in that way. The good news is, not to scare you too much, there are ways we can manage that and prevent that. So those are the three main transmission paths for hepatitis B. With hepatitis C, it is a much simpler picture. It's just the first of those three that we talked about, hepatitis B. So it's really just blood to blood. The infectious nature of hepatitis C does not extend down to the other bodily fluids, sexual fluids. In neither case, it pertains to saliva. You would have to drink something like, I think it's 20 or 30 litres of someone's saliva, which is not actually physically possible, and that's not a dare. So it's just blood-to-blood transmission. And again, I really want to emphatically make that point. It is blood entering another person's bloodstream. This is not just getting some on your fingers, which can be a common scare. So how that breaks down into specifics of transmission, I've got a couple of slides here, some of which are directly relevant to the AOD sector. Mother to baby transmission, as I mentioned, a very high chance, high risk with hepatitis B. With hepatitis C, it's really just falling into that category of blood to blood. You probably don't need me to tell you that there's a little bit of blood involved in childbirth, so there can be a risk there from mother to baby with Hep C, but it's much lower. It's more in the well, yeah, the inverse, about a 5% chance. Just for completeness sake, I've put in the grooming items here as well. I really don't want to scare anyone as far as just how infectious it is, but look, there is a possible transmission pathway. Sharing a toothbrush, not the best idea under most circumstances anyway, but when you're brushing your teeth, you can create, little micro fractures on your gums. You may leave behind some microscopic blood deposits. If another person is using that same toothbrush in a fairly short space of time, it is possible they could create the same similar sorts of compromises on their gums, and blood may get in that way. Clippers and razors, you can see there, there is a potential for some bleeding there. If they're shared, you have a transmission pathway. But I do really want to stress in both of these cases, this is a fairly low likelihood of a blood-to-blood transmission. More relevant to our work in the AOD sector, the transmission pathway of sharing snorting equipment. When we talk about Hep C, the poster child is sharing needles, and a lot of functional, habitual injecting drug users understand one fit, one hit. What's less perhaps well understood is the potential for other blood-to-blood pathways. So sharing snorting equipment, there are very fragile membranes in your nasal cavity. If they're compromised, through nosebleeds, if you're sniffing a powder substance up your nose, if we're sharing a straw or car key or whatever other implement people are using these days, there is a potential there, as I mentioned with the toothbrush, for blood to remain on the implement. It goes to the next person. We have a transmission pathway there. The next one, sharing injecting equipment. Again, we understand needles. What's less well understood is the potential for the other paraphernalia that goes along with safe injecting, any injecting, to get blood on it. So, we're talking about the tourniquets, as well as the fits, the filters, spoons. I was lucky enough to attend a safe injecting practice workshop recently, and even in a fairly sterile environment, and everyone with a self-contained little kit. For the record, we were mixing sugar and water. It was only practice. Even in that environment, it's actually incredibly difficult to maintain a sterile injecting apparatus. Just the way you're using swabs, brushing in one direction and not the other, that can even cause blood to remain in the environment. So you can see there in both of those instances, sharing is the big red flag there. And in the context of the people you're working with, people accessing your service, you really want to be listening out for that kind of disclosure as far as a potential risk of a viral infection. Less kind of going down the high risk categories here, workplace exposures, so needle stick injuries. Look, needle stick injuries happen in a lot of workplaces every day around the world. The actual instances, however, of a needle stick injury causing an infection, comparatively rare. I kind of liken it to shark attacks in terms of a reasonable psychological kind of public fear, but the reality is they're not happening all that often. I could probably quote, it's probably less than 10 a year around the world as far as an actual transmission of a bloodborne virus through a needle stick injury. And the last one on this list here, unsterile tattooing and piercing practices. Look, most tattoo parlors and piercing shops that you go into are going to have certification. You're looking for, as with any other kind of clinical setting, use of gloves, an autoclave. I know it's practice. Certainly in New South Wales, there is a certificate that they will display. You're looking to see that the needles used are currently in plastic, and I understand it's tattoo artists will make it that part of their procedure to actually show you that. But of course, this is referring to perhaps unconventional tattooing practices. So this could be in a prison context. I have a long history, as Sheridan mentioned, as a youth worker. Certainly in residential settings, the whole backyard tattoo job was not an uncommon occurrence. So there are lots of ways to get tattoos beyond a tattoo parlor. So that is something where you're looking out for a transmission pathway there. And the last of which is infected blood product. And I don't want to labour this point too much, but perhaps I mentioned that I have lived experience of hepatitis C treatment, and to satisfy your curiosity, this is how I came to have hepatitis C back in the 90s. So I'm a hemophiliac, which is a type of bleeding disorder, and hemophiliacs and other people with other bleeding disorders worldwide were subjected to contaminated blood products. We only started as a public healthcare system screening really successfully for hepatitis C in the late 80s, early 90s. So the blood bank ran a very successful backtracking program to identify cases of contaminated blood products. It wasn't limited to people with bleeding disorders. This would also describe people going in for organ transplants, other procedures, and so forth. But anywhere where blood was needed. I would say that I do want to stress the point that all these procedures these days are completely safe, but they weren't screening for, it's the same with the HIV virus, they weren't screening for Hep C and HIV before they knew these things existed. So I'm a person who contracted hepatitis C through the medical system. So this is also to be aware, just in basic non-judgmental practice, if a person's presenting to you, they have Hep B, they have Hep C, or whatever other conditions they might have, not to make any assumptions in your assessment of how they came to be exposed to these things. The bottom line is everyone needs treatment, and then I certainly want that to be one of the public health messages and practice messages to take away from today. So now that I've spent the last few minutes trying to scare you with every single possible way you might get hepatitis B or C, I also want to wind this back, put it in context, and perhaps bring us down to earth a little bit. What you're seeing here are a lot of myths, a lot of the perfectly reasonable and natural questions that come up when I'm conducting these sessions at drug and alcohol clinics. Can you get it through mosquitoes? Can you get it through holding hands? Can you get it off a toilet seat? In all of these 6 scenarios you've got here, you can't get it through mosquitoes. That might be, in kind of a horse sense way, it kind of makes sense. You'd think you could get that through mosquitoes, the way that mosquitoes operate. Goodness knows there are a lot of other conditions you'll get through mosquitoes, dengue fever and a very long list of conditions, but for whatever reason, it's not carried through to other animals, other species' DNA. So mosquitoes actually will not give you hepatitis. Simply speaking, if that was the case, we'd probably all have it by now. Sharing food. Now, this should kind of make sense coming out of what we talked about with transmission pathways, unless you are eating food covered in blood and you've got a cut in your mouth, you don't have a transmission pathway. So you're not going to catch it from eating food, even if it did have infected blood on it. Even with cuts in your mouth, that's still fairly unlikely. Your saliva, that's the main thing that saliva does, is break stuff down. Your oral to oral transmission is extremely unlikely. Point in fact, I was updating my first aid certificate recently, and I actually had to politely correct the first aid trainer about the likelihood of catching hepatitis B or C through an oral transmission. Extremely unlikely. You'd really almost be having to go out of your way to get that transmission pathway out of that. Following on from there, kissing in the same category. Breastfeeding, this one does actually have a slight caveat to it as far as teething babies, cracked nipples, but again, very low transmission likelihood. And I certainly don't want to create any stigmas in terms of a maternal health perspective. There are so many health benefits to mother and baby around breastfeeding. But yeah, so in the likelihood of both of those scenarios occurring at the same time, it is possible, and this is where you kind of want to widen that picture out when we talk about pregnancy screening should be catching hepatitis B and hepatitis C diagnoses anyway. Public toilets, again, much like the food, you're not going to catch it by sitting on a public toilet seat unless it's covered with blood and you're sitting on it for some reason and you've got cuts all over the backs of your legs. So again, I think we could fairly easily dismiss that as not really a transmission pathway. And holding hands, again, without that caveat of, if you want to change these scenarios up and think about transmission pathways, yes, if both people had open cuts on their hands, it will be possible. But in day-to-day living, cohabitating with someone, share housing or whatever, you're very unlikely to get a blood-to-blood transmission that way. I'm fairly emphatic on this point because, in our work at Hepatitis Victoria on the info line, just very recently we had someone call in who had been given a hepatitis B diagnosis by a doctor. They were instructed to go home and tell their housemates. This person was of asylum seeker background and had had a lot of time finding housing. That person was ejected from their housing on the spot because of the fear around a contamination of hepatitis B, lacking this kind of just basic health education about how these viruses will spread or not. So I really want to emphasize that point, that in day-to-day living, you're not going to catch hepatitis B off a partner, a housemate, etc. With hepatitis B, the prevalence of it throughout the world is, as I mentioned with hepatitis A, where you're going to find hepatitis A is where there's a breakdown in basic social services that perhaps a lot of us in Australia are taking for granted. The slide I've put up here is on the global picture of hepatitis B. The darker areas you can see there, I apologise, I know it's a very small picture. The darker areas are areas that carry more of the disease, those populations. You can kind of see here, I think in some ways this graphic perhaps is saying more than it's intending to. The burden of disease is carried by sub-Saharan Africa, indigenous populations throughout northern Canada, Latin America, Greenland, and throughout Southeast Asia. I think there's a fairly easy link to make between equitable access to social services, to conflict zones, health literacy, education, basically all the social services that perhaps a lot of us listening to this recording are taken for granted. If you're wondering why Canada and Greenland are divided up that way, that is recognising indigenous populations. I assure you that if the Australian map was subjected to the same scrutiny, the burden of disease would absolutely be carried by Aboriginal and Torres Strait Islander populations, as they carry every other burden of social disadvantage that you and I might care to think up, basically. But yeah, look, coming into this role a year ago, I didn't know a whole lot about hepatitis B, so I was quite shocked to learn that around the world, hepatitis B is actually responsible for 10 to 12 times more deaths every year than HIV, and that is a number that is in the millions. So hepatitis B, it's a fairly silent epidemic. If you're wondering why you're hearing about this from me for the first time, and this is my own editorial on this content, I think that graphic there might hopefully illuminate the discussion. Certainly relevant when we're talking about social disadvantage, which obviously comes a fair bit into AOD service discussions. So priority populations, who is more likely to carry the burden of disease? I've put up a quick list here. So people from those areas on the previous slide: Aboriginal, Torres Strait Islander populations, injecting drug users, vertical transmission, mother to baby. Those are the main populations, and by no means are these individual points, these demographics here, siloed. You can certainly have a lot of overlap between those. And I also just want to delineate with men who have sex with men. It's just recognising. I apologise for the terminology being slightly incorrect as far as representing sex and gender. This is just really recognising any anal sex as far as people's sexual practices. So that's as applicable to other demographics there. We've come up on the poll.
We're going to do a poll.
Wonderful.
So we might just pause, thank you, because there's a lot of incredible information there. Actually, I'm learning a lot today.
Oh, that's
So we're going to pause just to do a poll, and just it's a good point to just stop and just see what kind of what kind of information, and also the general kind of population belief. Well, certainly for the people who are watching today.
Yeah.
So the poll question, and so I'm going to just ask Redback, our IT technical people at the back, to put the poll up.
Getting a thumbs up. That's good.
Getting a thumbs up? Excellent. We'll all go. So the question that we're asking the viewers today, and if you could vote for which answer you think is the most correct, who should seek treatment for hepatitis B is the question we're asking. And so your possible responses are: everyone with a diagnosis should be seeking treatment in some way, or those people with signs of liver damage or who are pregnant with high viral Hep B viral load, or the third one, only men who have sex with men. So you won't be identified, it's anonymous, so have a go and choose your response. And it's just really interesting to, it's kind of thought-provoking. It gets you reflecting on, your own beliefs as well, and what you already know. And we'll just give you a few seconds just to have a go. So I'm actually looking at it on my iPad at the moment. I'm not sure if people can see the responses, but so far, the first response, everyone with a diagnosis should be seeking treatment in some way, is at almost 88%, and then 12.5% of people are saying the second one, those people with signs of liver damage or who are pregnant with high viral Hep B viral load. Nobody is saying only men who have sex with men. So we'll just give it one more sec to see if anybody else wants to put in a response. Yep, so we can close that poll off now. Thanks, Redback. So yeah, that's kind of your results are interesting. So we got a couple more.
Oh, just one stuck in under the gate.
On the bell.
Well, look, Sheridan, that's a real relief. That's correct. The first answer, all the above, is the best answer. And I, hopefully I drummed the point home without really hitting it too much over the head. This disease is not siloed to a particular segment of the population, even though they're carrying the burden of disease. Anyone with a diagnosis needs to seek treatment for hepatitis B. So, as a good launching point for continuing, look, I'm guilty in the past of using the words treatment and medication interchangeably. My colleagues at St. Vincent's Hospital, who run the statewide corrections program for treating prisoners with hepatitis, who assisted in developing this presentation, really wanted me to nail this point as well. There is a difference in general, but with hepatitis B, between treatment and medication. Treatment means access to the medical system. Treatment could be blood tests, treatments could be counselling. It's some sort of medical intervention. Whereas medication, of course, is, we're talking about actual substances that are imbibed or, some way taken into your body. So with hepatitis B, we don't really have time to go really into the pathophysiology of how it's working. It is quite complicated. The virus can fluctuate in a person's bloodstream, and this really just needs to be monitored by a gastroenterologist, by a liver clinic, by a hepatitis B specialist. And as a service, Hepatitis Victoria can certainly help you in identifying those clinics. They can be surprisingly hard to find once we're out of the metropolitan area. So yes, not everyone with hepatitis B needs medication, but everyone needs treatment. Medication is prescribed by a doctor, and it will be prescribed to you if your liver is showing those signs of fibrosis and cirrhosis, or at different times. So in the scenario of a pregnant woman, pregnancy screening happening, a hepatitis B diagnosis is caught or discovered, there are medications that can be given, that will be given, to help prevent a transmission vertically between mother and baby. So depending on how much damage your liver has absorbed at different points along the timeline, you might need medication for a while. You might be okay without it, just getting those regular blood tests. So, towards the later stages of cirrhosis and liver cancer, that would obviously be a big risk factor, and that's where probably the doctor would be prescribing more treatment. What the actual medication is, it's just pills. There are two brands listed here. Tenofovir and entecavir, one's for children, one's for adults, just with differences in your immune system. Like it or not, children have a better immune system than us adults will ever again. Another point to emphasise is, and I'm sorry I've put it in red, which might not be the easiest to read, but I really wanted to underline this, that we are managing, in this discussion, this is about managing a chronic condition. If you have hepatitis B, you have it. There is no cure for it. You're managing a chronic condition. In this way, I'd kind of liken it to diabetes. It's a condition that we don't have the magic wand, the magic pill to get rid of it yet. But if you're following the doctor's orders, taking the medication as and when it's prescribed to you, there's absolutely no reason that should have any impacts on your health. These medications are designed to help lower the viral load, prevent all that damage that we discussed earlier about that can be occurring to your liver. The good news from that rather bleak picture about having hepatitis B for life is, well, with a vaccination, we can basically ensure that you don't ever get it in the first place. So, as with hepatitis A, hepatitis B has a vaccination available. It's completely effective. It's given in 3 doses, so the original dose, a month later, 6 months later. Again, as with the Hep A vaccination, if you ever went to a travel doctor, chances are you would have been given at least one of the original shots, with probably an extracted promise from you that you'd come back and get the other in a month or 6 months' time. God knows I've never gone to a travel doctor 6 months out. I am not that organised. I know from my own clinical placement and just by talking to medical professionals that I think increasingly this is a requirement for for employment in a clinical setting. There's a whole raft of serology that you need these days, and Hep B really should be included on there. One of the benefits of being able to go through the at-risk and priority populations earlier is this directly translates to people who are eligible and able to access those vaccinations for free. That's a health initiative by the state, I think even the federal level. So anyone recognised in any of those demographics is entitled to get that vaccination without having to pay for it. And that does include workers with exposure-prone procedures. So moving on now from Hep B to Hep C, there is no discussion of a vaccination because there is no vaccination for Hep C, unlike A and B. The flip side with Hep C is there is now an effective cure, which we have for neither Hep A and Hep B. In this respect, they're kind of opposite day. Diagnosing hepatitis C, as I mentioned, is a blood test. And there can be a lot of confusion around blood tests with hepatitis C. If you're just going into a standard, checkup, usually HIV and Hep C are included in a raft of STI tests. If you're just going into a clinic and asking for a Hep C test, chances are you're just going to be getting that first one, that antibody test. And that it will only tell you that you've been exposed to the virus or not. It doesn't actually tell you that you've got the virus. The PCR test is the second more detailed DNA level test, and that will determine, if the virus is still present or not. So even though I took treatment for hepatitis C years ago, had a cure for it, the PCR test I would respond negatively to, but I would still test positive for Hep C antibodies. So testing positive for Hep C antibodies doesn't necessarily mean that you've currently got the hepatitis C virus in your blood. Moving on now, so the priority populations, won't labour that point too much. It's very similar to hepatitis B through the transmission pathways. What I really want to get to is the medications that are available. So in context, I took interferon in the early 2000s to treat my hepatitis C. It was successful for me, otherwise, frankly, I wouldn't be sitting here right now. But that treatment had a lot of side effects. Very low success rate. It was very arduous. It didn't work at all in a harm minimization context. and it was very difficult to get prescribed. With all the structural social barriers that prevent people injecting drugs and socially disadvantaged people from accessing proper medical care in the first place. The new treatments, I mean, I say new, they've been available for over 3 years now. It is the complete opposite of that. These are non-invasive, it's pills. You can take between 24 to 8 weeks. I think there's even a shorter duration available now. And you're not laboured with all those side effects. They're completely effective in a harm minimisation context. That is, just to clarify, they're not incompatible with injecting drug users, with alcohol consumption. The medicine will still have efficacy. It is on the PBS, so it's able to be prescribed by pretty much any community health clinic. You'll have at least one GP there that will be able to prescribe these. It's not a complicated medication. There are online tools. You can check compatibility with other medications. There's very few medicinal interactions with these. So I really want to label this point as well. In a harm minimization context, the direct acting antivirals, these medications, will work regardless of if you're an injecting drug user, a chronic alcoholic, etc. So that can often be one of the barriers to treatment around accessing medication. Historically, injecting drug users were not prescribed this as a risk factor because the medication simply wouldn't work if it was hampered by other substances. That is not the case with the new treatments. And if you're encountering a doctor who is not going along with that public health message, then my advice is simply try a different doctor, because I am here today to tell you that these medications should work regardless, regardless of any other medications you're taking. They can be managed. That's just a quick chart of the medications that are available. I'm not sponsored by a pharmaceutical company. Those are just the brands that are there. You can kind of see they're going from, at least my left to right. The original treatments that are available, Harvoni, 24 weeks. The most recent one, Maverat, now down to 8 weeks. For the 5% that's missed out on the 95% effective cure rate, there is actually an alternative medication that's just become available in the last couple of months. So the treatment picture is now it's 100% effective. If you have hepatitis C of any strand, you can now take a medication that will effectively get rid of it in just a couple of months with very, very minimal side effects. And most people report, in fact, no side effects at all. Moreover, people who have had chronic hepatitis C taking this medication in a lot of times have reported to me anecdotally of feeling really good on the treatments because their liver has started to work for the first time in years. So just rounding out the conversation now is I've mentioned already about the barriers to treatment, so stigma, discrimination, and how they can prevent people from accessing treatment. In the past, there was a real burden to have to disclose all your details to services in order to get on that treatment. People may not wish to admit that they have a hepatitis C diagnosis because it engenders certain ideas. And we really want to try and break down those barriers and encourage people to get treatment. Doesn't matter how you got the virus. It only matters that there is effective medication here to prevent it and hopefully get rid of it. So I'm just a little bit conscious of time. I just wanted to say there's a few, you're not required to disclose your status to anyone in terms of employers. Even in an intimate context, this is not legislated. The only exceptions to this is if you're donating blood, if you're taking out life insurance, if you're joining the armed forces, or if you want to be a cage fighter and you have a hepatitis diagnosis. I'm sorry to tell you that you might need other career options. Other than that, there is no burden on you to disclose a status. People do get this confused with HIV, where that is a condition that is notifiable and you are legally required to disclose it. Hep C and HIV often get mentioned in the same breath as the bloodborne viruses relevant to this sector, but no, Hep C is not legislated to that extent. So yeah, just supporting someone who's taking treatment, just recognising that this might be a chronic condition they've lived with for a long time, and just to support them. And yeah, one thing about hepatitis C that I should also delineate before we finish is that it is possible to get reinfected. Lacking that ability to vaccinate, there is nothing to stop you from catching a different strand or the same strand even of hepatitis C again. So you really need to shift that conversation with someone who's being supported through treatment around safe injecting practices, or risk adverse behaviours, avoiding those transmission pathways, because it is possible to, in every instance I mentioned before, to do that, to prevent a transmission. So yeah, we have a few services that are available. Our info line is available during business hours. You're welcome to call and clarify any of this information. We can provide referrals to different services throughout Victoria, and we have analogues in all the other states as well. We have an app called Liverwell, which is available to help manage your just liver disease and liver health in general. They even suckered me to help out with the tutorial video. I think I'm even wearing the same shirt, so there you go. I do own more than one shirt, I assure you. But no, look, I use it. It syncs with the Google Calendar. It's free. It's on Google Play. Highly recommended. We have a health promotion team who can come out and talk to groups of people who are accessing your service. It's not a one-on-one service. That's really what the info line's for. But we are available to come and help promote the liver health message. We also run a program, or several programs through custodial settings, prisons throughout Victoria. That's just a quick summary for when you're downloading these slides. Which ones can be vaccinated again, which ones can't, which ones we have an effective cure for, which ones we do not. Yeah, so look, apologise for running a little bit over time there, but that's pretty much everything you need to know within an hour on viral hepatitis. So thanks for listening, and feel free to chime in with any questions.
And we do have a couple of questions, actually.
Right.
You did really, really well, actually, fitting all that in. And everybody can download those slides. So if you've got any things that you did want to follow up with, Stephen, then you can make contact.
Absolutely.
Yeah. Okay, that's great. So yeah, you can go ahead and download those slides and have a look through that, and do make contact. There's just a couple of questions. One did come in earlier, which was, you mentioned that cirrhosis is the liver being decompensated. Is that the wording? Can you explain what it means? So cirrhosis.
Yeah, it's funny because I remember we were talking beforehand about trying to avoid questions that get too much into the biochemistry or the anatomy physiology. I can't go into too much detail on it's basically cellular breakdown as, on a physical level, the granulation tissue forms of fibrosis. It is actual scarring of the liver that is preventing blood from flowing through it, and it is, I don't want to misspeak and say it's necrosis, but it is basically the tissue dying off, the liver not able to maintain its integrity.
And you have provided a link in the slides if people want to go to that, because there's more information.
Yeah, absolutely. Yeah, I apologise, but we have to be fairly brief, and I don't want to burden you with too much, anatomy physiology stuff here for a treatment perspective.
You did start to answer this before, but somebody did ask, what are some of the barriers that you've seen in people seeking treatment? Are there any other things you wanted to say to that?
Well, yeah, thank you for that. Yeah, that's a really good point. I mean, I've mentioned a couple of anecdotal instances where people have been prevented from getting a prescription for the direct-acting antivirals. I certainly don't want to throw all the GPs that you might encounter under the bus. I'm only talking about the rare outliers, but barriers to treatment can be as far as getting a prescription from perhaps a fairly judgmental community health service or a particular GP. I've heard, and again, this is really just a few instances out of dozens and dozens of sessions where I've done, where people have been turned away from a doctor from admitting to being an injecting drug user, where that conversation should shift towards safe injecting practice. It should absolutely not be a barrier to getting access to that medication.
And you did mention before that your recommendation would be that we recommend to our clients to get another GP.
Yeah,
just go for another
second opinion.
Second opinion.
Shop around.
We did have another question, which is different. It's just somebody wanting to know, where did you do your safe injecting practice workshop?
Oh, great.
Do you want to give a shout out to someone?
Yes. I did it through Harm Reduction Victoria. And it was very well done. And they're our colleagues in the bloodborne virus community. Very well worth taking the time to do that.
Beautiful, thank you.
Thanks, Sheridan.
Stephen, I want to thank you so much. You did a lot of work there in a really short time frame, and I know that this is the first time you've done it as a webinar.
Yeah, sorry, I did get a bit greedy with how much I tried to include.
I think you did a great job. And I've learned a lot as well, especially around this idea that there's a healthy carrier. That is actually something that I've heard a lot about, and now I'm understanding that's not exactly how we can see it.
I really wanted to steal that whole "every cigarette is doing you damage" slogan and stick it on my presentation, but because it's a very parallel, similar message.
Yeah. Well, thank you so much for spending the time with us and sharing this information, especially in this format. So we really, really appreciate that. I know we're kind of at the end of our time together, so I did want to just be quick and ask if you can stay on the line and do our quick exit survey so we can get your feedback, because we're planning into 2020, so I want to get your ideas. But also let you know that we have another webinar on the 24th of July, and it's by one of the Turning Point researchers, and his name is Tony Barnett. And the topic will be the brain disease model of addiction and implications for practice. So 24th of July, same time. We'll be starting to promote that, so you'll be able to go to the Eventbrite and hold your spot for that, and then also, of course, get the link for the replay. So please look out for that on the Turning Point website, and it will be going through the VADA e-news as well. Thank you so much for spending your time with us today, and we'll see you next time.